Hello, my name is Vikesh Singh, and I'm a professor of medicine and director of pancreatology in the Division of Gastroenterology at the Johns Hopkins University School of Medicine. I would like to thank the course directors, Drs. Enrique de Madeira and Hernandez Barco, for giving me the kind invitation to speak to you today about specific treatments for acute pancreatitis, new drugs for an old disease. I have the following disclosures, but none are relevant to the content of my presentation. As an overview, we will discuss four topics today. The first is, why don't we have a therapy for acute pancreatitis? The second is lessons from prior trials. The third is primary and secondary prevention. And finally, we'll finish up with future potential therapies. Why don't we have a therapy for pancreatitis already? There have been many agents tried with little success. This is a nice review by Dr. Paul Lankish and published back in 2006, which listed the many drugs which have been used to treat acute pancreatitis, as well as their mechanisms, and the results are effectively labeled as effective and ineffective. And as you can see, most of the drugs were deemed to be ineffective. And even for the drugs that were shown to be effective, further studies had, in many instances, shown them to be ineffective, especially once larger sample sizes of patients were enrolled and followed for longer periods of time. What are some of the reasons why we've not been successful thus far in developing a drug to treat acute pancreatitis? One of the first reasons is that animal models of acute pancreatitis poorly recapitulate human disease. It's often joked that if humans were mice, then we would have already treated acute pancreatitis successfully. This is a nice review written by Dr. Fred Gorlick and Marcus Lurch that was published back in 2017 that did a nice detailed analysis about some of the differences between rodents and human beings with regards to experimental models of acute pancreatitis. The second reason is that the optimal target in a disease with complex inflammatory pathways can be often difficult to identify and target. So we know for a stimulus, in this instance, a stimulus that causes acute pancreatitis, and the subsequent inflammatory response can have many intermediary molecules and cytokines. So one of the questions is, do you target something like the red dot here, which would only potentially shut down one part of the inflammatory response, or do you target something like the green dot, which might actually shut down more than one pathway of the ensuing inflammatory response? One of the other questions that often comes up is, are we missing the interventional window due to the variability in patient presentation and time? This is a hypothetical figure from a surgical review published nearly 25 years ago, showing that from the onset of abdominal pain to ER presentation, cytokine production, and subsequent organ dysfunction can all take place in a period of 1 to 2 days. And that may be the window in which you have to act with regards to a treating drug. So if a patient delays presentation to a healthcare setting, it's quite possible that they might present at a stage of organ dysfunction or cytokine production, at which time a drug may be deemed ineffective. One of the other problems that often comes up is that predicted severe acute pancreatitis usually ends up not being severe acute pancreatitis. This is a nice study that was published by George Papacristo and his team at the University of Pittsburgh back in 2012 that utilized 3 prospective cohorts of patients, 2 from the United States and 1 from the Netherlands, and divided this large cohort of patients into a training cohort and validation cohort to evaluate the ability of existing clinical scoring systems to predict persistent organ failure, as that is actually the primary determinant of mortality of acute pancreatitis. And as you can see in the validation cohort, the positive predictive value of these scoring systems was somewhere between 11 and 23%, which is quite low. However, the negative predictive value was quite high at 94 to 95%. So overall, in patients who are found to have predicted severe acute pancreatitis, most of them do not end up having severe disease. The next question comes up, and that is, what is the definition of severe acute pancreatitis that you use? Everyone is familiar with the Atlanta classification of 1992, which separated the severity of acute pancreatitis into two binary choices. One is really mild and severe disease, whereas subsequent severity classifications, including the revised Atlanta classification and the determinant place classification, further stratified severity based on the presence of organ failure and infected necrosis. What we have come to learn over time, though, is that infected necrosis without organ failure is associated with very low mortality. So the primary determinant of mortality in acute pancreatitis continues to be the presence of persistent organ failure. One of the other issues that comes up is that we know that large sample sizes are required for clinical trials with hard endpoints. So in acute pancreatitis, if you look at the left-hand side of this table, if you look at the different outcomes, including persistent SIRS, necrosis, persistent organ failure, mortality, which is only 1% in all comers with acute pancreatitis, but can be as high as 30% in severe acute pancreatitis. You can see that on the right-hand side, if you look at the potential of any drug to achieve relative risk reductions of anywhere along 10 to 50%, you can see that the number of patients needed for any of these various outcomes would be staggeringly high. And as you can also imagine, that a drug with a 40 to 50% relative risk reduction would be considered a real home run and often difficult to develop and achieve those kinds of relative risk reductions. One of the recent developments in at least the monitoring of pancreatitis disease activity is something known as the pancreatitis activity scoring system. This is the first study that sort of highlighted the potential of a scoring system to be utilized in patients with acute pancreatitis on a daily basis to see how their disease activity would modulate. I think it's important to note that this is composed of a total of 5 different parameters, which are listed up top. And as you can see, there is a weighing of, or the weight of organ failure is much greater than all of the other parameters. Yet, on the other hand, tolerating a solid diet was given relatively high weight compared to the presence of systemic inflammatory response syndrome. So there are some questions that arise from using such a scoring system. And this was, again, also tested to look at predictions of clinical outcomes in acute pancreatitis, more specifically the development of moderate to severe acute pancreatitis, as well as early readmission. But I think it's important to note that since the scoring system already is weighted heavily towards organ failure, a lot of this is happening in parallel and is not necessarily a predictive system at baseline. We're going to now move into some of the lessons from prior trials. One of the first studies that was, let's say, more well-known and critiqued for evaluating a platelet activating factor antagonist lexipifant was published back in 2001 in the journal Gut, and really looked at the role of lexipifant for the treatment and prevention of organ failure and predicted severe acute pancreatitis. This had come out of the United Kingdom, led by Colin Johnson. In this study, a total of 290 patients with an Apache 2 score of greater than 6 were randomized within 72 hours of symptom onset to intravenous lexipifant, administered at 100 milligrams every 24 hours for 7 days. And the primary outcome was organ failure and/or local complications. As part of their sample size calculation, they expected a 40% relative risk reduction from 40 to 24%. However, some of the problems with this study were that 44% of the patients had organ failure at the time of randomization, and there was no difference in the rates of new organ failure or local complications between the two groups. 75% of the cohort presented within 48 hours of symptom onset. So, we can certainly say that the ambitious 40% relative risk reduction suggests an underpowered study. More recently, the Mayo Clinic group evaluated pentoxifylline in severe acute pancreatitis. This was a pilot, double-blinded, placebo-controlled randomized trial. They uh, they randomized 28 patients with predicted severe acute pancreatitis to pentoxifylline 400 milligrams 3 times a day or placebo within 72 hours of symptom onset for 3 days of treatment. They found that there was a significantly shorter hospital and ICU length of stay in the pentoxifylline group. However, some of the issues were there were a lot of patients who met exclusion criteria, and many patients actually did not consent to enroll in the study, leading to a very small sample size. And there was a very broad definition for predicted severe acute pancreatitis, and certainly the issue of late treatment initiation. One of the other trials that comes up is one that was primarily conducted in Japan, looking at the role of continuous regional arterial infusion of protease inhibitors. And the whole point of this was to use protease inhibitors to potentially reduce the risk of pancreatic ischemia and subsequent pancreatic necrosis, as well as capillary leak syndrome and the potential for developing organ failure. However, a retrospective multi-center cohort study eventually found, once you got to larger numbers of patients, that CRAI really had no efficacy in the treatment of severe acute pancreatitis. And some of the reasons were that there were lower mortality rates in prior studies due to the impact of co-interventions. They surmised that this might only be effective in necrotizing pancreatitis and not necessarily in severe acute pancreatitis alone, which would, of course, be the presence of persistent organ failure without necrotizing pancreatitis. And there was the requirement that this needs to be started within 72 hours of symptom onset and administered for no longer than 5 days. So certainly if there was a delay in presentation of a patient for the initiation of treatment, they would potentially not be enrolled in the study. There's also the issue of the impact of co-interventions. And of course, we all know that intravenous fluid therapy is ubiquitously used and is considered a part of the standard of care for acute pancreatitis. This is the Waterfall trial, which Dr. Enrique de Madera is the first author on. And of course, this is also a landmark study which evaluated aggressive or moderate fluid resuscitation in a randomized manner among patients presenting with acute pancreatitis. But one of the important things to note here is that the aggressive fluid resuscitation arm was associated with a nearly threefold higher risk of volume overload compared with the moderate fluid resuscitation arm. So let's say you're conducting a randomized trial of a new drug to treat acute pancreatitis. You certainly would need to continue to administer standard of care. So if in this study, hypothetical study, one was to give aggressive fluid resuscitation, many of the patients might develop volume overload and the symptoms of volume overload, leading one to either discontinue the trial or assume that the side effects of aggressive fluid resuscitation could be then attributed to the drug of interest, as opposed to recognizing that it was just simply giving too much fluid. We're going to talk a little bit about some of the progress that we've made in primary and secondary prevention, because let's remember that an ounce of prevention is worth a pound of cure. The only primary prevention that we currently practice in the field of pancreatitis is prophylaxis of post-ERCP pancreatitis. We know that there are patient and procedural factors that help us categorize patients into average and high-risk groups. There have now been several epidemiologic studies which have given us the overall cumulative incidence of post-ERCP pancreatitis, severe post-ERCP pancreatitis, and death. Among average risk patients, this turns out to be 10.5 and 0.2% respectively. And the high-risk patient cumulative incidence of PEP, severe PEP, and death are also relatively close at 14%, 0.8%, and 0.2% respectively. The main methods that we use for preventing post-ERCP pancreatitis are the use of intravenous lactated ringers, rectal NSAID suppositories, and pancreatic stents. Our own group, in conjunction with colleagues in India and Europe, published this network meta-analysis back in 2021, comparing intravenous fluid different forms of rectal NSAID suppositories, as well as different caliber pancreatic stents in order to determine if any of these compared to each other or placebo were actually superior. What we found was that there were a number of agents which either alone or in combination were significantly better than placebo. However, there could be no conclusion made about one being more superior than the others because of the overlapping 95% confidence intervals on this forest plot. The recent stent versus indomethacin trial was completed after a Herculean effort that spanned nearly 7.5 years and enrolled almost 2,000 high-risk patients for the development of post-ERCP pancreatitis. And the patients who were randomized to indomethacin alone, the incidence of post-ERCP pancreatitis was 14.9%, whereas those patients who were randomized to indomethacin and pancreatic stents, the incidence of post-ERCP pancreatitis was 11.3%. The difference was 3.6%. However, the 95% confidence interval crossed the non-inferiority margin, which was set at 5% prior to the start of the trial. So the conclusion drawn from this study is that indomethacin alone is not non-inferior to the combination of indomethacin plus pancreatic stent. So at this present time in high-risk patients, combination therapy with indomethacin and pancreatic stent would be expected to be of greater prophylactic value than indomethacin alone. There has been some development on the role that calcineurin inhibitors might be effective in preventing post-ERCP pancreatitis. There are at least two nice mechanistic studies that have been published by Sohail Hussein's group at Stanford, looking at how the contrast agents that are injected into the pancreatic duct might actually activate calcineurin and the calcium signaling pathway and result in post-ERCP pancreatitis. And as a follow-up to this, there is a large international multi-center study which is currently underway that is conducting a 2x2 factorial randomized control trial of rectal indomethacin oral tacrolimus, which is a calcineurin inhibitor, or their combination for the prevention of post-ERCP pancreatitis in all-comer patients. This is called the INTRO trial. To date, this study has randomized a total of 976 patients, but the planned sample size is nearly 5,000. So this might take a couple of years, but I think it's going to answer a very important question. Turning our attention to secondary prevention, there are a number of secondary preventions. Of course, there are the common ones that we talk about commonly, including the role of cholecystectomy and biliary pancreatitis, alcohol and smoking cessation, and lipid-lowering therapies for those patients with hypertriglyceridemic acute pancreatitis. And then there's the experimental therapies, including CFTR modulators for patients with recurrent acute pancreatitis who have pancreas-sufficient cystic fibrosis. There are also certainly some uncommon secondary preventions, including corticosteroids for recurrent acute pancreatitis and type 2 autoimmune pancreatitis, discontinuation of checkpoint inhibitors in patients receiving those drugs for malignancy, and endoscopic sphincterotomy, let's say for type 3 choledococele. And then there's some controversial secondary prevention procedures, including endoscopic sphincterotomy for recurrent acute pancreatitis due to pancreatic sphincter body dysfunction or pancreas divisum. And of course, the granddaddy of all options, total pancreatectomy with islet autotransplantation for recurrent acute pancreatitis. This was a nice study published by the Mayo group back in 2012 that showed that a lack of significant liver enzyme elevation in gallstones and or sludge on ultrasound on day 1 of acute pancreatitis is associated with recurrence after cholecystectomy. This study enrolled patients in different groups, categorized as group A through D. A were those patients who presented with elevated liver enzymes and gallstones and sludge on ultrasound, and D were those patients who had neither liver enzyme elevation or gallstones or sludge. And as you can see, certainly in those patients, if you don't see an elevation in liver enzymes or the presence of gallstone sludge, the risk of recurrent pancreatitis was high after cholecystectomy. Let's also keep in mind that an ALT of greater than 3 times the upper limit of normal has a greater than 95% positive predictive value for acute biliary pancreatitis. So even if you don't see gallstones or sludge on the day one ultrasound, but you see an elevated ALT, that is highly likely to indicate acute biliary pancreatitis. Many of you know about the Poncho trial. This was a multi-center randomized controlled trial conducted in the Netherlands, which randomized patients to interval cholecystectomy versus to same admission cholecystectomy among patients with acute biliary pancreatitis. And as you can see, one of the conclusions of the study was mortality or readmission for gallstone-related complications was quite high in the interval cholecystectomy arm at 17% versus the same admission cholecystectomy arm at 5%. And what's even more interesting is that the patients who reported biliary colic type symptoms during the waiting period leading up to cholecystectomy, particularly in the interval cholecystectomy arm, was 51%, but only 3% in those patients who underwent a same admission cholecystectomy. So really the final conclusion here is that for patients with mild gallstone pancreatitis, inpatient cholecystectomy is the primary recommended intervention. Let's also remember it's much easier to stop drinking than smoking. We know that from a NICE trial conducted in Scandinavia back in 2009, that if you can stop patients from drinking after a single episode of alcohol-associated acute pancreatitis, you can prevent a second episode and thereby also prevent the eventual development of alcoholic chronic pancreatitis. However, in a separate study, which evaluated efforts to achieve smoking cessation in a chronic pancreatitis population, they actually found that none of the patients were able to stop despite an intervention. So this is an important thing to keep in mind. There have now been 2 trials which have evaluated novel lipid-lowering therapy specifically for patients with familial chylomicronemia syndrome, otherwise known as FCS. These are patients who have deficient or complete absence of lipoprotein lipase activity and tend to have sky-high triglycerides that can only really be treated with extremely low-fat diets. Because if you use any of the conventional lipid-lowering therapies, they all act through requirement of having functional lipoprotein lipase. And therefore, these patients don't achieve triglyceride reductions with anything other than an extremely low-fat diet. So this is the first trial that just came out a little earlier this year, looking at olezarsen. And olezarsen is an antisense molecule that binds to the messenger RNA of ApoC3 and results in very significant triglyceride reductions in patients with familial chylomicronemia syndrome. And as a secondary endpoint in this study, they also showed that there was a decline in the number of acute pancreatitis events among patients who were randomized to the olezarsen 80 milligram and 50 milligram arm compared to placebo. However, this was a secondary endpoint, and this was not found to be a statistically significant result, but nonetheless, it suggests that there could be a role for these drugs in preventing recurrent acute pancreatitis. And more recently, another drug for patients with familial chylomicronemia syndrome was also studied in a randomized trial. And this drug is known as plozasiran. And plozasiran is a small interfering RNA molecule that shuts down ApoC3 production from the liver. And this study, as a secondary endpoint, also evaluated the rates of acute pancreatitis and did find a significant reduction in the rates of acute pancreatitis in those patients who were randomized to plozasiran compared to those who were randomized to placebo. I'll just finish up this section with showing that we know that if you use CFTR modulatory drugs, you can reduce the risk of recurrent acute pancreatitis among those patients who have pancreas sufficient cystic fibrosis. Remember that patients with pancreas insufficient cystic fibrosis rarely develop acute pancreatitis because they generally don't have any Acinar cell mass left. So this was a study that we had published now almost 5 years ago that looked at the initiation of CFTR modulator therapy across a total of 15 patients with pancreas-deficient cystic fibrosis who had a history of recurrent acute pancreatitis, and there were no acute pancreatitis events after initiation of CFTR modulator therapy over a mean follow-up of 3 years. In fact, when we have looked at these patients in the 5 years since this study, none of the patients who will continue to be on CFTR modulator therapy have had an episode of acute pancreatitis. And while this was not a randomized controlled trial, you can see down below there was a separate group of 8 patients who were not started on a CFTR modulator, and they continued to have episodes of acute pancreatitis. So I'm just going to finish up with some of the future potential therapies that are being evaluated for acute pancreatitis. We know that there has been a lot of interest in targeting calcium signaling at the level of the Astner cell. Some years ago, there was a drug known as DPB99. This was developed by a pharmaceutical company called D-Pharm based in Israel. This is an intracellular calcium chelator. This was initially evaluated in stroke patients, and then subsequently they turned to an acute pancreatitis population. And they conducted this study primarily in Eastern Europe and Russia. And while the study was completed, I don't know if there was a significant result because they never published their final results. One could also certainly try to shut down calmodulin activation, and there's not been an active drug that's been trialed for this. But I think the most promising target that has been evaluated to date is known as CM4620, otherwise known as Oxora, and this is developed by a company called Calcimedica. And this targets the crack channel on the cell surface of Astner cells. And by tackling this calcium release activated calcium channel, one can prevent extracellular calcium from making its way into the Astner cell and resulting in the pathways that lead to acute pancreatitis. In their preliminary study, Oxora was evaluated in 21 patients with acute pancreatitis and accompanying systemic inflammatory response syndrome. And as you can see, 8 received low-dose Oxora in standard of care, 6 received high-dose Oxora in standard of care, and 7 received standard of care alone. And as you can see, the percentage of patients tolerating a solid diet was much higher in the Oxora arms at 72 hours or discharge, or by 10-day or discharge. You can see that the red bars represent what percentage of patients were tolerating a solid diet. As you can imagine, it's a relatively small study to look at hard clinical endpoints. But if one could tolerate a solid diet and potentially be discharged from the hospital sooner, there would certainly be an economic argument for this drug to be utilized in patients with acute pancreatitis. They are currently, they have just recently completed this study known as a CARPO trial. And this is a randomized, double-blind, placebo-controlled dose-ranging study of Oxora in patients with acute pancreatitis and accompanying systemic inflammatory response syndrome. This is a 4-arm study looking at placebo as well as 3 different doses of Oxora. They have randomized a total of 216 patients as of this past May. We are awaiting the results of this study. And once they're published, then I think there may be some role for potentially utilizing Oxora for the treatment of our patients with acute pancreatitis, certainly in the sense that it might reduce the overall length of stay and allow patients to get to a solid diet a little bit faster. There has also been some interest in using antifibrotic agents in patients with predicted moderately severe and severe acute pancreatitis. Investigators led by Vikas Dudeja at the University of Alabama are exploring this in a clinical trial. This drug, pirfenidone, is already FDA approved for the use for the treatment of patients with idiopathic pulmonary fibrosis. This is still enrolling patients, so we don't quite have the results yet, but it could be an interesting idea to reduce fibrosis as maybe not even necessarily as a means of treating acute pancreatitis, but maybe even potentially preventing acute pancreatitis in those patients who already have a history of recurrent acute pancreatitis. There is another drug known as RABI 767. This is a small molecule lipase inhibitor of fat necrosis, which can be injected around the pancreas using endoscopic ultrasound guided injection. And the idea is that if you can inhibit fat necrosis, you might actually prevent worsening of acute pancreatitis, particularly in those patients presenting with predicted severe acute pancreatitis. This study is now enrolling at several centers around the United States and could represent a very interesting interventional drug treatment for the treatment of patients with acute pancreatitis. So I want to finish up with the key points of my study, of my presentation. The first is there are, at this point, no tailored pharmacologic therapies for pancreatitis. Care continues to remain supportive. There are several important considerations for the design of future trials, including, do animal models, do we need better animal models to translate to human pancreatitis? Probably yes. We need to try to target inflammatory mediators and cytokines that are early in the overall inflammatory cascade. We know that the time of onset of symptoms to presentation of ER can be highly variable, so certainly very important to enroll patients within very set timeframes from the onset of symptoms. We know that there is, of course, the problem of predicted versus actual severe acute pancreatitis. Certainly patients who are already presenting with organ failure, like in the lixipafan trial, it may certainly be too late to actually start them on treatment and expect a positive outcome. We know that there's variability in the definition of severe acute pancreatitis. We know that there has overall been a lack of control for co-treatments that we know impact outcomes. And certainly I had brought up the example of the waterfall trial and showing that those patients who are randomized to the aggressive fluid resuscitation arm had significantly higher rates of clinically detectable volume overload. We know that most prior studies have been underpowered and there are no clear, universally accepted clinical trial endpoints. We are making some headway with primary and secondary prevention, and these will continue to develop. And finally, I think the new drug treatment that may be closest to clinical use at the present time is going to be crack channel blockade using the drug Oxora now that it's completed its larger phase study. And with that, thank you for everybody's time and attention.